exciting panel. I think that everyone's really going to enjoy this perspective that we're bringing today. It's a very different perspective, one we haven't heard of before. There's been a lot of talk about regulation and rules that are coming. Well, we've only talked about it from one perspective, and today we're going to hear about it from a different perspective, one that's equally as relevant, but I think often overlooked, and that's really from the perspective of the developer. Can we go to the next slide, please? So before we get started, just a couple of reminders. Everybody is muted. If you do have a question, please submit it in the Q&A box. And if you're in the Q&A and you see a question you like, give it a thumbs up. That's going to put it to the top of the list so that we make sure that we can answer the questions that are most pressing to you, the audience, because we want to make this as engaging and interactive as possible and make sure that we answer the questions that are most pressing to you. If you have any technical difficulties, please submit things in the chat box. I have my colleague who is monitoring the chat box, and also look at the chat box for references to materials you might hear about today and for some of our email addresses. Next slide. So today's agenda, I'm welcoming you. I'm Wynette Dixon. I'm the Director of Programs and Strategy here at eHealth Initiative and Foundation. And today we have three wonderful speakers, actually, sorry. My colleague, Catherine Pugh, who's the Assistant Vice President of Policy here at EHI. We have Jennifer Blumenthal, she's in the top left, or my top left, with OneRecord behind her. She's the CEO and co-founder of OneRecord. And we have Ruby Raley, who's the VP of Healthcare at Axway. Welcome, ladies, and thank you for being here. They're going to give us a really great discussion, and afterwards we'll answer all the audience questions. If you hear something along the way you have a question about, please feel free to submit a question at any time. As I said, we want this to be interactive. Sarah, please, next slide. And this is all of our members. EHI is a membership organization, and we take pride in being a multi-stakeholder organization, bringing all of these wonderful partners and members together. It is really because of our members that we are here today. And they are the reason that we're able to bring you such wonderful programs and such wonderful reports. And we appreciate the support of our members. If you're not a member and you're interested, please email us. I'll put my email in the chat, and I can tell you about what membership is and the benefits and how you can be involved with EHI. If you're already a member, I just want to say thank you for your continued support as we've grown, and we celebrated our 20 years already. Next slide. And this is our work. We really fall into three buckets. We do education and advocacy and thought leadership across a number of really important topic areas. And the way we do our work is through webinars such as this. We have work groups, and we have a number of comment letters, and we're very involved in paying attention to current policies, hence what we're going to be talking about today. And this is just an example of the many ways that we do engage with our members and with the public. Next slide. For us, there are four critical issue areas that we focused on. One being data privacy. This is a very, very important topic for us, and also virtual care. Through the advent of COVID-19, there's been so much around virtual care and how it's being accessed, who can access, and the importance of it. And SDOH, which is my bucket of work. I focus heavily on our social determinants of health work and our AI. And all of it really culminates into our COVID-19 best practices. I think that speaks for itself. We've been talking about this a lot for the past year, and I imagine that going forward in the next year or so, we'll continue to talk about these areas and will remain at the top of our list. Next slide. This is just a list of our recent forums and webinars, as you can see in our different areas across privacy and COVID-19 and telehealth. We've been focusing on health disparities. And if you want to look at our past webinars, please go to our website, ehidc.org. All of our recordings from the past webinars are there, and reports. They're all free for you to download, free to access, and they live there in perpetuity. They're never coming down. So please take your time and peruse through all these materials. Next slide. And these are some of the publications we put out last year, and there's actually one coming up this year. Be on the lookout for that. It's on maturing virtual care in the tribal communities. Next slide. And this is just a list of some webinars we do have coming up. Next week, we have one on COVID-19 vaccine administration and tracking. If you haven't registered for that yet, please go to ehidc.org and register today. And we have a couple of exciting ones coming up in May, one on consumers and advancements in data technology, and the other on interoperability and physician burnout. Next slide. And of course, we have to thank our sponsor, Axway. Without Axway, we wouldn't be here today. So we do want to thank our sponsor. And with sponsors, a number of our sponsors, they support our webinars and our many events. And without their support and our members' support, we wouldn't be able to be the small but mighty nonprofit that we are, bringing these wonderful programs to you. The next slide, please. So this is a lovely picture of me and all of the panelists that you have speaking to you today. And with that, I would like to turn this over to Catherine so that she can begin to talk about, give us some background on the rules and like what they mean. And then she'll be facilitating our conversation and we're gonna have a brief Q&A. Next slide.
Thanks, Renee.
You're welcome. Thank you, Catherine.
Hi, everyone. Good afternoon. I'm glad you could join us this afternoon. I know you all are probably digging in and have attended a lot of webinars on the information blocking and interoperability rules that came out of ONC and CMS and are starting to go into effect this year. So I wanted to actually take a step back and bring us back to what is now 5 years ago, well, 4.5 years ago, and set the stage for a discussion that Jennifer and Ruby are going to have around the consumer experience in healthcare and how fast things change when it comes to regulation and how the healthcare system works. So just to give some background, as many of you know, the 21st Century Cures Act actually set the stage and the requirements for the rulemaking from ONC and CMS around information blocking. The health IT provisions in the law focused on interoperability, information blocking, and the regulation of health IT. And this was really driven by a frustration that despite government investment in the adoption of EHRs, there's still a lack of meaningful and useful health information exchange or interoperability. Next slide. So fast forward 3 years. I can tell you, so with my previous organization, was very heavily involved in the lobbying and advocacy for the information blocking and interoperability provisions in the 21st Century Cures Act. And as many of you probably were as well, you all remember that the intent of the law was actually to ensure that providers have access to their patients' health information. Information blocking, when we first started meeting about it, was basically my hospital can't talk to my emergency room. My emergency room can't talk to my hospital because they're on different platforms and those EHR vendors are not talking to each other. That was in 2015 and 2016 when we were drafting the law. So fast forward 3 years, the landscape of digital health and the flow of data through the healthcare system has changed significantly. And the Trump administration was putting out the proposed and final rules on information blocking focused on patients having access and controlling their own information versus providers. And HHS felt this was key to moving toward true interoperability. Next slide. And so I just wanted to go through a couple of key takeaways from the ONC final rule. I just wanted to remind everyone that the law actually only required ONC through rulemaking, to establish exceptions to information blocking. Obviously, ONC went a step further, and the two main areas that the ONC rule covers are health IT certification and information blocking. And the information blocking exceptions that ONC was required to establish in the law were to represent reasonable and necessary activities that do not constitute information blocking and to establish a public reporting system. ONC, in going a step further, requires actors to make electronic health information available to patients and any entity of their choosing, including third-party applications via certified API, which Ruby and Jennifer are going to go into more detail on. Next slide. Coupled with the ONC rule, at the same time, CMS put out a rule around interoperability. CMS is requiring Medicare Advantage plans, basically all of their payers that they regulate, which are listed here, to implement and maintain a standards-based patient access API. And payers also must allow third-party applications to retrieve at the direction of the patient certain data. And this also was a step further than the law. The only requirement in the CURES law was to establish appropriate disincentives for providers who are found to be engaging in information blocking. Quite notably, CMS actually has not issued regulations on that yet. So that will be very interesting to see where that comes out. Next slide, please. And then the final area, which I think starts to transition to what Ruby and Jennifer are going to talk about, the consumer experience in healthcare, is key regulations on price transparency. And that kind of gets to the point that once you combine price information and clinical information, you can really start to create a consumer-driven healthcare system. And so a few recent rules around price transparency. In October 2020, HHS issued a final rule requiring payers to disclose price and cost sharing information. And also, a very controversial, HHS issued a hospital price transparency rule, which is now in effect, that requires hospitals to provide pricing information online as a machine-readable file and display shoppable services in a consumer-friendly format. And as I mentioned, controversial, hospital groups have actually filed suits to block this rule. And so to be determined on how that, what the future holds for that rule. Next slide. So what's next? I think that increasing transparency in a consumer-centric healthcare system is bipartisan. It's not a partisan issue. A lot of the rules that I just mentioned have a lot of support. Even though they came out of the Trump administration, they have a lot of support from both Democrats and Republicans. And even last week, bipartisan Health Committee leaders sent a letter to HHS Secretary Becerra urging him to enforce the hospital transparency rule. And so I think what the future holds are more consumer-friendly regulations. One of them, the No Surprises Act, passed in December, that bans so-called surprise billing beginning on January 1st, 2022. So HHS is going to need to promulgate rules on that this year. And I think that's just one example of what's in the pipeline, but I think we're going to continue to see this increasing shift in consumerism in healthcare. And I think we've even seen that from the intent of the 21st Century Cures Act when it was passed in 2016 to where we are right now with the rules that came out in 2020 and how fast that shifted from, okay, providers need information to patients need information to we're going to go even further and make sure there's price transparency and more consumerism in healthcare. And so I'm actually going to turn it over at this point to Ruby Raley, the VP of Healthcare at Axway, to talk more about that consumer experience in healthcare and where the industry is headed next, since we've seen such a shift in these few years.
Thanks, Catherine. I appreciate it. Next slides. One more. Since we all have to have an advertisement, here's my advertisement. I'll let you read it as I kind of introduce the topics. I've been working on this interoperability rule with a couple of key accounts for over a year now, really intensively in the last probably 9 months. And I bet that everyone on the call that's in industry is in the same sort of mode. And it struck me over the summer last year that this was a sea change. It really was transformative. And why? because before, and I've worked with HIEs, I've worked with connecting systems up. A lot of what Axway does is integrate with file movement. So there's a ton of portals for people to post files to. We do that work every single day. All of those connections have historically been done in a project. So the payer would have a project manager, they would send an email out to the provider would get a project manager, the two people would talk, there would be a companion guide defining all the fields, what they mean, they discuss it, they get ready to test, they keep meeting, and over a period usually of weeks and months, they go through this process and they get some tests done, and then they mutually decide to go live. That's not how things are going to work in July when this interoperability rule goes into play. A third-party developer is going to come to your front door and try to find your APIs, try to use those APIs, and then want to go into production with you, and you have no business relationship with them. You don't know them. You don't have a project team. You don't have a project manager. Your call center probably doesn't even know what these APIs are about. So, Jennifer and I happened to find each other in the process of public speaking, and she represents that third-party development experience. And you're not going to be successful with this rule if you don't think through these challenge questions. So I really encourage you to listen to Jennifer and challenge both Jennifer and I with questions you might have about your own implementation. And I think it's going to be really fun to just think about how things are changing in healthcare and the new questions we all need to ask. So Jennifer is the CEO of OneRecord, which you can advance the slides now, is an important third-party consumer company that's helping gather all this data up today. Go ahead, Jennifer.
Hi, I'm that third-party application you all fear. I thought I would start with talking about what is a third-party application, because I hear people this kind of negative connotation when people talk about third-party applications. It kind of feels like a dirty word, and I think that that's kind of a misrepresentation of what the legislation calls for. So when I think of a third-party application, I don't just think of an iOS app, an Android app. I think it could be a browser extension, it could be a desktop app, it could be a web app, it could be even just something that visualizes data for consumers. Or I've been telling a lot of people that I really think the future of third-party applications in healthcare are going to be hybrid approaches. So people leveraging, both a B2C model and then a B2B model, and the B2C model kind of helps that B2B model. And I think that that's going to be a little troublesome for people to swallow as they're thinking about what is a third-party application when they come knocking on their door. But that's Ruby's problem, because she has to think about what a third-party application is. What we have to think about is what is the patient experience. And for us, a big problem in building that patient experience, building the future of healthcare, is how do we connect to these FHIR servers? Where are they? Who's hosting them? Is it being built by, like in this case, we're going to talk about payers. Is it being built by the payer organization and they're hosting everything in-house and they're doing everything themselves? Or are they working with third parties? And are those third parties the, documentation we need to read? And then how do we even find out who is connected to who? Let's say, this is just me talking. Let's say a Blue in a state. How do I know who's helping that Blue? And if, let's say, Axway has some customers and we go to Axway and we connect to them, how do we do that? Where's the documentation? What's the developer experience like? How do we even register? Who's going to respond to our emails? This is a very long and tedious process for all these third-party applications. And I think we're just at the beginning of, we're in year 0. This is like interoperability year 1 for payers. So you can go to the next slide. So I thought about getting ready for this webinar, and I thought about the kinds of things that we want to build for patients. So for us, we've been very successful with provider organizations in enabling consumers to choose us as a third-party application of their choice and connect to their data. And part of that process has been the discoverability of their provider organization through their EHR vendor. So for us, over the past year, the biggest lift has been connecting directly to the EHR vendor, getting approved, getting our client ID in secret, putting those URLs into production, and then making it discoverable within our user experience. And we've been speaking about this publicly a lot, but for us, when we work with partners, and a big thing for us is not just, okay, where's the developer portal? How do we move to production? But what information are you going to give back to us to make a really great consumer experience? And you have to think it's going to be beyond what kind of app experience it lives within a mobile phone. So, that's kind of how I've been thinking about how third-party applications are going to be calling FHIR servers. Ruby, maybe you want to talk a little bit to, I told Ruby the other day that the way I kind of think about it is, I don't think it's a very good analogy, but I really like it, so I'm going to say it, I was explaining this to a friend of mine. It's almost like you have to be able to speak French and you have to know the address for a city and in France, and that's kind of the way you communicate with these servers. And they're like, no, that's horrible. That doesn't make any sense. So I was like, okay, well, maybe it's like you have to be able to speak Spanish to know the address in a Spanish city like Madrid. And then the problem is, if you speak Spanish in Spain, there's different dialects in South America, and there's a little bit of different flavors, and that creates a problem in communication. And we kind of experience that right now as a third-party application, in not just, reading someone's OAuth documentation, reading their FHIR documentation, reading how to even get everything set up and what their policies are around even making their customers aware of a third-party application. So I kind of think about FHIR as a little bit like Spanish all around the world. There's a little bit of a different flavor for each country, and you have to be able to kind of adjust your Spanish speaking for each country that you're in.
I agree. I think it's really different for plans. We've all listened to all the complaints about how the EHRs could be blocking data exchange, or how you get charged to do a data exchange. But really, Epic and Cerner particularly have come a long way. And the alliances like Karen and others have come a long way. And there are known ways, and Jennifer is well connected with all of those, to get data out of those platforms. But with health plans, and there literally are hundreds of them, there isn't a well-defined path. And as Jennifer notes, some of the health plans are building their own portals for developer experience. Some are buying from companies like us. All of them are looking at FHIR servers. And I am worried that some of them think that standing up a FHIR server is all you need to do. And that's just not the case at all. As Jennifer's already pointed out, she mentioned that you have to get a secret to connect to EHR. And in API land, we typically say a token. That means you have to have some sort of capability to grant that token to a third party. And you have to have some way to get all this documentation that Jennifer was just talking about. How does that happen? Like, where is that? Like, this is the experience that's missing. And to get the data to move out of the health plan, it's going to need to have this sort of new modern take at it. And Jennifer, I think you dig a little bit deeper as you go forward, so I'll hand it back to you to carry on. But I will say that I love your Spanish analogy, but I would say, since I've been doing this for a while, that, we've gone through a lot of versions of things in healthcare. So we all had the 5010 EDI uplift, we all have the standardization on that. We've all done, IHE, we've done a lot of things. There's a huge difference with open API versus all those other things which were project-based, like I said before. We're looking at true consumer-grade self-service in healthcare. And are we really ready for it? What do you think, Jennifer?
No. So I would say over the past year, and even into the months leading up to July, it's still pretty messy. You look outside healthcare, and there are so many APIs available to developers, and it's built by developers for developers, and we just don't have that in healthcare. We are a team, we're all US based. We all have had healthcare events, and that's really what, helps us build and inform the development of OneRecord. And something that I think is important is, like, let's say, we're successful in connecting to Axway, and we're enabled with an Axway customer. And then we get that secret or that token and we move to production. There's still a problem with, okay, it meets the spec, but how do you make your plan available to the consumers in a consumer format? And those are the kinds of things that I'm hoping that as people think about standing up their APIs, the slide that I put together, the opportunity is they're working with their partners to think just beyond what compliance means. And it was pointed out earlier in the conversation that, you know, CMS really hasn't dictated a lot of what compliance means. And I think we're in version 1 of this rule. I think that when I look at MU3 and I look at HIPAA and I look at, you know, patients' rights to access their data under HIPAA and the references to that in Cures Act, I see those 3 rules have to be how people think about, well, what's going to be year 22 look like, 25, you know, 28, and then 30. And everyone should be thinking, well, we shouldn't just be thinking about our patients, we should also be thinking about our developers, because our developers, and that when I say developers, third-party developers, actually service the patients because they're the vehicle that consumers will get their data from. And another way to think about it is, you know, individuals could come up and they're going to be building their own apps. I mean, there's going to be a whole generation of kids who know how to write code. They could spin up apps left and right. They're not even going to be organizations. So imagine when your organization or your partner organization is getting spammed with emails just asking to move to production. It's something that I think payers and even provider organizations still, and put pressure on their EHR vendors to think about, well, what does developer first experience look in healthcare to power the patient experience?
That's an interesting question, Jennifer. And I was wondering if you could talk, we were talking a little bit in our prep call for this, that I talked so much about how the rules focus on patient access to their information, and that's so important. We all support that. We haven't, I don't think, really done a webinar yet from the third-party developer point of view, but you all, because you're not really subject to the rule, although it enables you to get a lot of information. But just given that, you know, as a consumer myself, I turn to developers to make it easy for me to manage my health information. You know, even if I can access it, I'm still going to be trusting and reliant on applications like yours to really help me manage that data. Can you talk a little bit about how you help the consumers that you work with manage their data?
Well, I think that it's right now it's so early adoption for the rules because they all just went into effect. I mean they didn't all just go into effect, but you think of April 5th as the first, you know, compliance date in a way. When we think about helping people manage their data, we think about first helping people find their data. So with the way we think about it is there's 2 ways to find your data. If you have a set of credentials, that's going to allow you to unlock the OAuth FHIR workflow. But how do you find it is important. And then there's the question of what do you do with it? So are you just storing your data? Are you just aggregating it, downloading it, deleting the application and leaving? Do you want to do something with it? So right now we have kind of 3 goals for this year, which is to help people get to their data, aggregate their data, and then do what they want with their data. And I think a future state is going to really depend on data quality. That's a really big thing that no one's really talking about. Some people are talking about, but the data that we're seeing coming in isn't the best quality. And how are consumers going to get to report back on that data? That's what I'm most interested in. There is a work group at HL7 for patient engagement that's talking about, you know, that patient generated data where they're commenting on inaccuracies. And then I think the opportunity is actually the true consumerism of healthcare. So if you have all your clinical records and you have all your clinical, financial, and formulary data from your payers, past and present, going forward, it'll be very interesting what kind of consumer-based experiences you can build. When I started OneRecord, I really was thinking about, you know, the Expedia of healthcare, the Kayak of healthcare. How can you shop for care? And how can you find the best price and the best treatment through the right channel? That's what drove me to be interested in this space. And I'm still really interested in that. And I think this is the beginning of that opportunity.
That's really interesting, Jennifer, because, oh, sorry, Ruby, go ahead.
No, I was going to change the topic slightly. So you finish and then I'll make a little note. Go ahead.
No, I was just going to say that it's so interesting how many healthcare entrepreneurs I have talked to that have wanted to increase that consumerism, or that, you know, the shoppability in healthcare, and especially, you know, as high deductible plans become more prevalent, there is a real impetus for consumers to want to shop around for some of the costs of procedures that might not be covered under their deductible. So
I, like, personally as a woman, we consume a lot of healthcare early on. Like, we're already seeing specialists as soon as we hit adolescence. And so,
right.
And we move a lot, and we need to be able to compare, is this the right provider for me? And it takes a couple of tries to find somebody that you're comfortable with. And I think, you know, I was an early adopter of Airbnb and anything that is an aggregator that allows me to search and find something that works for me. And also, I'm a master, you know, e-commerce shopper. Like, this is just how I've grown up. This is how I interact with, you know, websites and applications. And I think that's also a lot of developers, they want healthcare to mirror their life outside of healthcare. And that's the, you know, customer experience I think is going to be built. And a part of that is also making sure that you can actually connect to the data, which goes back to, you know, how do you find the partners that are working with the payers, or how do you partner directly with the payers to be able to access those APIs so you can build those experiences?
Yeah, I'd just like to chime in that this problem is harder for the health plans. You mentioned, Catherine, that, you know, the CMS is covering the health plans that they are the payer for. In other words, Medicare, Medicaid, the federal exchanges, state exchanges where they exist, and so forth, of the children's health insurance. That all of these plans can be actually run by the same health company, by the same health plan, can have different policies that they write in all these spaces. Each of these policies has a different ID. You know, we've all been complaining about provider IDs and patient IDs. We haven't talked a lot about the plan IDs, but for Jennifer, as a developer coming to a plan, she has to find out from her customer, how did they engage with this health plan? Like, there's nothing in the regulation that requires the health plan to expose in one spot the plans that they've operated that are covered under this rule. And so they've all taken different approaches to it. Like, some of them have a combined set of APIs, and they have a facade that goes in, that is a very common term you'll hear from the health plans. Of facade is where there's basically kind of a proxy API or an API that sits in front, and then behind the scenes, other APIs are gathering the data up and consolidating and then handing it over to an application like Jennifer's. None of this is standardized, right? And what's really fascinating to me is the social determinants side of it, which EHI specializes in. So let's say that I'm the working poor and I'm able to work sometimes with health benefits, but oftentimes I fall into, you know, I have to go on to Medicaid, or I have children, so they're on the health insurance for the state, and then I get my job back and I get them covered again, and then they go back and forth. So within the 5-year period that plans have to collect all this data, what if I've been on and off your platform 3 or 4 times? Like, this is why you might want to have OneRecord, because if your child has been sick, right, you don't want to pay for all of these tests to be run over and over again for your child as you move on and off plans that have different doctors that are part of their networks. And we begin to see how, from a consumer point of view, this portability of healthcare information and the portability of the test results really becomes something that we've never had before. And it opens up the door for all kinds of things. But right now, today, it is causing headaches for the health plans who are trying to figure out how to make this work. It's causing headaches for Jennifer, who is trying to figure out, well, how am I going to build one way to do this? And you're telling me I'm going to have to speak literally hundreds of dialects of FHIR and APIs in order to reach my mission. Like, that's not acceptable. Like, how can an industry expect that there's literally hundreds of ways to do the same thing? And it doesn't matter that we're all using the same bulk FHIR API. It matters about how you get to that bulk FHIR API.
Well, that's actually a great setup for one of those questions that we have in the Q&A box, and that is that the question is, how does the fact that FHIR is a framework and not a single API impact what you all are talking about? I think you were getting to that, Ruby. And that there's no single definition for how to do one thing that everybody does the exact same way.
Yeah, so let me give a short answer and then Jennifer can talk a little bit more about it. So when the health plans will tell you, oh, I've been working with FHIR for 5 years now. And I've seen that. I went to the HL7 payer summits. I talked to them. They were doing great work. But all that work was for provider to payer. And all of those situations have much more defined information points that help guide where to pull the data from and how to use it. And also, they're all covered entities. So all the rules are different there, right? Now, all of a sudden, we've got patients like Jennifer sitting there. Who is Jennifer? Does she have the right to get any of this data? Like, I don't know her at all. Like, she looks a little shady to me. So am I just going to open all my FHIR APIs up and let her just choose the one she wants? No, I have to have security. I have to have some structure. I have to have something I didn't have to have before, because this is now public. Now, when Jennifer comes and tries to get this data, and I'll let her speak to that, even if you all went to Smile CDR and you downloaded the pre-work there and you use the data model, the UCSDI, that doesn't mean that the whole experience is all going to be consistent. Jennifer, you want to take it over?
Yeah, so I think to bring this back to reality, we have a mixed team of people who've been in healthcare for, their whole careers, coming from the EHR space and the payer space. And then we have people who built consumer products. And when the people who built the consumer products, when we talk as a team about just connecting to the APIs, their minds are just blown. Like, they can't even fathom the hoops that we've been jumping through to just even test against people's test environments. Currently, for us to connect to a FHIR server, we have to, a lot of times find the hidden form on a website, get approved, talk to somebody. Right now, we're getting sent a lot of security assessments to, validate, what are our security and privacy practices. And I think that this is from the payer side, because it's just such a new space for them. And I think that the real opportunity would be like, well, what would you want as a developer? Or how do you want to represent yourself in the world to build a developer experience? Because right now, the barrier to entry is still very high for apps to build, just because everybody's kind of working out the kinks and the processes and what their servers are going to look like and what their API documentation is going to look like and what that FHIR flavor is going to look like. Like, FHIR is a standards format, but it doesn't come always in the same way for everybody. We see people, interpret things differently, and we can adjust as an organization very quickly for that, just because of our experience and our bandwidth and our ability to move quickly. But for, a single developer trying to build a cool app to like help his mom, it's going to be hard.
Well, you both, Ruby and Jennifer, hit on security and privacy. This is something that EHI has worked a lot on, as you probably know, because these rules really highlight where there's a gap in federal regulation now, which is that OneRecord. Jennifer, you likely don't sign business associates agreements with every payer or provider that you connect with, and therefore you are not HIPAA covered. You are not covered by HIPAA. And their question here, I think, hits on that that gap, and that I'm going to rephrase this a little bit, because I do want to use this question to try to also clear up some of the misconceptions around HIPAA and this rule. The question is, since the covered entity is ultimately responsible for the privacy and security of the patient's public health information, where did the, oh, there it is, sorry, the question disappeared. There's concern about fraudulent and misguided use of data once that crosses the HIPAA threshold, and that patients don't realize that this is the case, that their data is no longer covered by HIPAA once it goes to a third-party application. And there's concern, I think, that the patient is then going to go back to the covered entity, and that covered entity has to go, has a few processes around security and authentication, I'm sure, Ruby, which you can highlight, but ultimately they're not responsible for that that misuse of data, and that's something that EHI is actually working on with our work around a consumer framework for, a privacy framework for consumer health data, and trying to bridge that gap of protections once that data crosses the HIPAA threshold. But Ruby, I know you were talking about some of the things that you're working around security and authentication, so I wanted to turn it over to you.
Yeah, so this is why you need a registration process. So just to be blunt, I'm a vendor. We sell API systems. We have a lot of competitors, whether they're selling FHIR APIs or they're selling general purpose APIs. A lot of these were not set up to actually connect to your identity management system. So one of the very most important things is you have to register this third party in your identity management system to get the token to give them to use the APIs. So just because this is an open API does not mean that you're supposed to expose your APIs to hackers. You can have a registration process. You should have a registration process. You need this information about who this person is. And for many plans, they've got whitelisted their IP addresses they work with. Your processes, your infrastructure will not work without a registration process. But you've got to think about scale. Like, we only have one Jennifer here today, but we can't tell you how many OneRecord companies are out there that are going to want to connect. You cannot keep doing this as a project. You have to put a self-service function in for the registration and the discovery of the APIs. And each FHIR API needs to be secured based on its usage. Once you do that, right, then Jennifer's team could come get their security token, browse your portal, see the APIs in action, get the documentation she described. You have to think about testing. Are you going to let somebody actually hit your system that's never tested with you? Like, are you or are you not? So you have to think about that. And then how are you going to promote them to production? Are you really saying that in this portal, there's a production API and Jennifer can go download it and call it and your system is going to let her through? No, you're going to need traffic management. You're going to need to have this security registration process, have this discovery process, but also have a traffic management process, because you've got like very large quantities of data that could be leaving your organization. What's that going to do to your network? You know,
yeah, Ruby, I just wanted to highlight one part of what you were saying, or actually all of what you were saying, and the tie back to the information blocking rules, which is that the security and privacy exception is for if you believe, if an actor believes that they are exposing their own system to security threat, not if they disclose a patient's health information, as that disclosure is then a risk to that patient's health information. So I just wanted to clear that up, that exception is for the security of systems versus the protection of patient health information once it crosses the threshold.
Right. So this is another big problem that it looks like we probably need another session to cover all of these problems, but there has to be consent. So as a health plan, you're going to have to figure out that Jennifer has the right to get this data. So did the patient who went on to OneRecord and said, I register with you, I authorize you to go get my data, like, how do you know that's true? right? So, and once again, there's no standardization in how that's being tackled. And I'm really fearful that people are using some old-fashioned member portal registration process. And I just need to remind all of you, it's true for providers and it's true for plans. How many of your members have actually registered on your portal? Do you have a digital identity for these people who want to get their data? How are you going to tell Jennifer that she can't have this data until that consumer creates a digital identity on your member portal and grants this? Like this whole connectivity, front end, self-service part is being neglected because we're so busy standing up FHIR and trying to consolidate data and get data from our pharmacy benefit PBM, get data from our records, put it in FHIR format, expose it, but we're forgetting the front end of the process. And Jennifer, I'm sure you have something to say.
I would zoom out for a second. So, you know, OneRecord's been around for a while, and when we first started, we've always been a consumer-facing application. And when we first started, FHIR wasn't a thing. It just wasn't in production. I didn't know if it was actually going to take off until it made it into Cures Act. It was just a standard that didn't have any meat and potatoes to it. When we first started working on OneRecord, we actually connected to national networks, state like Care Quality and Commonwealth, state HIEs, and the question you asked, Catherine, which is about security, risk, the wrong data being exposed, the wrong person accessing the data and it being exposed. And we had those same problems using existing standards. There's to me, there's two issues. There's the idea of digital identity. So you have an assumed digital, a consumer has an assumed digital identity because they have a set of credentials. And then there's also the concept of, well, what happens when those set of credentials trigger that authorization and FHIR flow and the data is given to someone? Is the person who put in those credentials actually the person who's assigned those credentials? And then the other part of that is the actual trust of third-party apps. We face that a lot on national networks. Even though people could see me, hear me, sign up for OneRecord, they're still like a third-party application. So what Ruby's talking about kind of is the first part of that journey, which is, you know, going through the registration process, getting permission, getting your client ID in secret, having a record, you know, everything within the security exception, everything around that is basic practices of API management. Then there's the part of you as a plan can't control when a consumer pulls their data because it's their right under HIPAA to get their data. So there's going to have to be a little bit of trust level. If OneRecord or an app that looks like OneRecord comes to you and says, I'm building this for the consumers, by the consumers, and they want their data, you have to get that API available. And when you make that API available, I think that's when the monitoring and management with partners allows you to be like, is OneRecord a good actor? Is OneRecord a bad actor? And that's when, you know, there will be chances. But also when the consumer pulls their data, it's no longer, you know, under HIPAA. It's, you know, we're governed by the Federal Trade Commission. And are we, you know, misrepresenting our services? Are we doing things malicious? You know, are there other privacy organizations within the federal government that could come after a third-party application? So I think, in my mind, the plan should be more focused on how they're going to make the API available, how they're going to make it easily available, and then there should be a period of monitoring. Because in reality, there's not that many apps in existence today. I would say there's like 10 that are really well known and maybe 60 that are live somewhere doing something. That's a very small cohort of apps. So you have this period of time to think about, how do we improve this process? How do we lock down any security flaws? And then how do we understand in future states, you know, who potentially is a bad actor? I mean, are they building it overseas? You know, what are they doing? You can ask what their, you know, goals are. I don't know. It's kind of like, it's a whole new world.
This is why you need a full featured system, because Jennifer and I run several thought problems by each other. So one thought problem is, she mentioned the garage developer. There's nothing to stop. I like to use my brother-in-law as an example, you can guess why, that he could go into his garage and code an app to help my mother get her health records. I would be cringing the whole time, but there's nothing to stop him. He doesn't know how big her 5 years of data is. and his little server in the garage can't handle it. So it fails. And he retries and he retries and he retries and it keeps failing. If he's retrying so much that I decide to block him. He goes and tells my mother that the health plan is blocking him and they're mean people and he doesn't know how to fix this. And she then registers a complaint for information blocking. So this is just one simple thought problem. The harder one for people who run infrastructure, which is a lot of who my customers are, is what's the traffic load going to be? How many Jennifers are going to log into my system on July 1 and download 5 years worth of data at one time? Is it 1? Is it 60? Like Jennifer and I don't agree on this question, by the way. It's like, but how do you operate a server in a network when you don't know what your traffic's going to be? Go ahead, Jennifer.
But I would say when that app, whether OneRecord or another app, does that, like, it's no longer, from how I understand it, how I interpret everything, once the consumer pulls their data, it's outside the world of HIPAA. And if the wrong consumer pulls it because they have their credentials, I don't think that that's going to be on the covered entities, because how did they get that set of credentials? There's no way to prove that the covered entity gave that credentials. I mean, transparently, I have the access to my dad's portals because he's older and he needs my help and he can barely use his iPhone. So that's going to be the first phase, and that's what people should be monitoring for, is just the traffic, how often they're pulling, you know, that's the kind of stuff I would do if I was on the other side of the phone.
Yeah, I would just say that Jennifer's absolutely right. There's so many gray areas here that you're just going to need to have your audit trails, and you're going to need to show that you operated in good faith. If you decide to block an app for whatever reason, you need to have a process by which that app can say, hey, I'm a good person, let me back in. And this is what I think is missing, is like, we have to have this self-service thing, because it's going to be just like the federal exchanges. When everyone went to register and the enrollment fell apart, and every health plan I know was hiring between 5, 10, even more people to just sit and manually process enrollment information until we finally got in a life cycle for the federal exchanges enrollment. The same thing is going to happen. We're going to have a process where something fails. We need to have an idea, even if we're hiring some people to monitor, so that we can recover. You cannot just leave Jennifer sitting outside with no way to find the solution to the problem she found. I have to say Jennifer's very innovative and she will find a solution. But we've got to think through how this is going to be operationalized. Go ahead, Jennifer.
There's a lot of great questions coming in and I'm not answering any of them, so I apologize.
Yeah,
no,
I was gonna.
I have answers to all of your questions, so just email me. But I think what I'm kind of seeing, we're talking about right now is the OAuth FHIR workflow. There are going to be payers with their, you know, their subsidiaries and then their plans who do not currently have member portals, and that's going to be a problem too, because there is no a member has never been credentialed before. So how do they authenticate to hit an OAuth workflow and then a FHIR API? There's going to need to be maybe, you know, traditional SAML authentication, bringing in remote identity proofing. This is going to have to expand beyond the current OAuth FHIR workflow to give all patients or all members access to their data. And, you know, I think for each infrastructure, they're going to have to kind of look at today, how do they handle, what is their roadmap for enabling consumers to get their data? And it's not going to be exactly what's in the spec, or it's going to have to be an upgrade to meet the spec.
That's great, Jennifer. Just one question, the one last question, I guess, is, so for so long, how do you see the future shifting to support more third-party applications like OneRecord? Because I think for so long, one reason that we didn't have interoperability is because so many of the incentives were in the healthcare system were pointed toward data hoarding. And the more data that you have, the more control that you have and the more money that you can make in the healthcare system. But that's obviously going to shift. And so what is your plan moving forward in like your business model and that you think is applicable across all third-party applications that really would drive consumerism in healthcare?
So mine or everybody's?
Well, I guess maybe both, yours and what you think is applicable across the industry.
I kind of see it in some big buckets. I think there's going to be the self-insured bucket. So the idea of, you know, you work at one company, you move to the next company, and the ability, and this is obviously a later phase, easily take your data to your new employer. I think there's the, I think for the payers that there's going to be a lot of value around new member enrollment and getting that really rich data set around incoming members. I think for providers and research institutions, it's really getting that full view of that patient on a patient level, records from everywhere across the ecosystem, whether you're treating a diagnosis state, pre-surgery, whatever. I think life sciences are probably going to benefit the most from this legislation. You know, just look at getting vaccines out into the market. Imagine if we can move new drugs and therapies to the market, which is called for in Cures Act. Like that's a big part of Cures Act is new drugs and therapies. I think interop is a big piece of that. And then I also see that there's just there's going to be, I mean, I think if people get really creative, just imagine the Jetsons and the connected home and all your devices. Like, will your refrigerator be able to know that you're a diabetic and it's going to decide your shopping list based off of, you know, and then submit that claim to say, oh yeah, you have been eating right, and here's, here's a $50 Amazon gift card to stay on track with your, your health plan and goals. I think it's very exciting and big, because what it's going to allow is not only the ability to shop for care but also to personalize care. And so I think long term it's really going to move towards that. But the blockers to get there is going to be it's going to be the data quality and the access to the APIs. If you can give access to the APIs and improve data quality, I think anything's possible, because people are creative. So that was big, that was very vague, but that's kind of how I see it. I think it's going to really benefit payers, life sciences the most out of the gate. Yes, and Jennifer, I will say, I think we are just about at time, but I agree, there are a lot of great questions here. So feel free to follow up with Ruby and Jennifer and myself. I know there's a question in here around the CMS prior authorization rule that was paused at the beginning of the administration. I don't really have a great answer to that, but happy to discuss further any policy regulatory related issues. And then on the privacy issue, wrap in my colleague, Alice Leiter, who is our senior counsel privacy expert and much smarter than I. She is a HIPAA lawyer. So if you have questions, we are here to answer them. And with that, I will turn it over to Winnie.
Thanks, Catherine. Thanks, Jennifer. Thanks, Ruby, for a great discussion. I think one of the biggest takeaways that came out of this today is there's still a lot of questions. There are a lot of questions and things to think about. And it's clear that we're going to need 100 more 1-hour sessions to like really dig into this. But there were a lot of great questions. If we didn't get to your question today, look for a follow-up email with me and I'll share everybody's contact information. And I'll also share a copy of the slides, and I'll send a link to the video in case you missed something. In a chat box, I think Catherine just put Alice Leiter's name and email address. She is our HIPAA lawyer. And we've got some really great sessions coming up. So please continue to look, and we'll see if we can continue the discussion. Again, ladies, thank you so much. And thank you again to Axway. And thank you everyone for joining us today, no matter where you are. We look forward to seeing you again. With that, have a wonderful, wonderful afternoon. Thank you. Bye.
Thanks. Bye.